This is going to be a brief overview of the lymphatic system, and we're going to divide it into two sections: innate defenses and adaptive defenses. Let's do a brief overview of the lymphatic system. And I want you to ask yourself the question, what is the lymphatic system and what is it doing? And there are two things that should stand in your mind right now, and that is fluid recovery, and the other one is immunity. Let's go through the fluid recovery section. Remember that in our capillary beds, as we're bringing blood flow to our tissues and we're delivering all of these nutrients, we're filtering out a lot of that fluid and we're only recovering a portion of it. So only 85% of the fluid that was filtered out is recovered. That means that about 15% of the fluid that was filtered out stays into the interstitial fluid. We need to recover this because if we don't, eventually our vessels, our arteries and veins will be volume depleted. Our recovery of fluid is going to happen through lymphatic capillaries. So these lymphatic capillaries will recover this fluid, and once it enters the lymphatic capillary, we don't call it anymore interstitial fluid, we call it now lymphatic fluid. And this lymphatic fluid is going to flow from vessels, lymphatic vessels, into lymphatic trunks, wow, my pen is not working, and those are going to merge and they're going to converge into a lymphatic duct. Okay, and then those ducts are going to dump into the subclavian veins. And we can see now that we have that fluid recovery. Along the way, as we're passaging and trying to bring this fluid back to the subclavian vein, we're filtering out this fluid and we're cleansing it. And with the help of immune cells, we are cleaning out pathogens or destroying pathogens, diseases, and this is the second function of that lymphatic system, and it is immunity. The second question that I want you to ask yourself heading into this review is, what are the components of the lymphatic system? And there is a couple of them. We're going to divide them into tissues, cells, vessels, and organs. So we're going to put in here, vessels, as we spoke. We're going to put in here cells, organs. We're going to put in here tissues. So the vessels, as we just briefly mentioned, we have lymphatic capillaries. We have those lymphatic capillaries will go into lymphatic vessels. Now those vessels will merge, and once they merge, they will create a lymphatic trunk. And those lymphatic trunks also merge eventually, and then they become a lymphatic duct. And it is the lymphatic duct that eventually ends up dumping the lymphatic fluid into that subclavian vein. And the movement will be from capillaries to ducts. There is a couple of cells inside those lymphatic vessels, and the collecting ducts and those are T cells, B cells, and K cells. There are other cells that are also involved in immunity, And we will discuss this further, but remember that we have innate defenses and we have humoral defenses or adaptive defenses. These are more so related in particular to the humoral defenses. The other leukocytes, such as neutrophils, eosinophils, basophils, are also playing a role in immunity, and we'll discuss them as well. However, they are more so related to that innate immunity. Okay. As far as organs within that lymphatic system, we're going to mention the bone marrow, which is one of our primary organs. Here we're producing all of our lymphocytes. We have the thymus. Remember that the immature T cells that are made in the bone marrow do not mature in the bone marrow, but they mature in the thymus. We have lymph nodes, which are sections of a congregation of multiple immune cells along those vessels. We have the spleen, and we have other tissues, and those are mucosal associated lymphatic tissues. There are different types, and these are called bolt, amongst others. But they are referring to diffuse tissues. There is a congregation of cells, lymphocytes, that are protecting that tissue. So think of areas such as your intestines, such as your tonsils. We have cells that are ready to attack pathogens. So we refer as the general term for them is MALT, mucosal associated lymphatic tissues. And again, it is a congregation of lymphatic cells so that they can attack when there is an pathogen coming in. The BALT specifically is related to the bronchial associated lymphatic tissue. So when you breathe in a pathogen, we have some of these cells ready to attack. Okay. All right. Now, lastly, we have the last question, and that is you need to remember what is in immunity, the difference between adaptive versus innate defenses. Your body has multiple mechanisms to fight organisms that can cause disease. So within our innate defenses, think of your skin, think of neutrophils, think of mechanisms like inflammation. Um, think of also a something that is called complement. We will see later that complement plays a role in both innate and humoral immunity. But overall, this is defenses that attack anything that is abnormal. All right. Now, this is different from adaptive defenses, and the adaptive defenses are, they're known because they attack specific diseases. So if you have immunity against a certain flu strain of a virus, that will make you less likely to get a so sick when you get infected. Immunity means that you're carrying a specific antibody to attack that type of pathogen. Now, this is just again some of the elements and some of the organs. The organ that we're missing here will be the bone marrow. All right, these are the four main organs. Primary organs will be your thymus and your bone marrow. And these are the other tissues that we discussed about. You should differentiate between lymph nodules and lymph nodes. They are not the same. Lymph nodules means that there is a congregation of lymph cells, and as we talked about, when there is a congregation or a lot of cells that are packed, we call that mucosal associated lymphatic tissue. And there are different types of MALT. All right, either be in your respiratory tract, your urinary tract, um, if it is in the respiratory tract, we oftentimes term it as BALT. In your GI tract, we call it as GALT. Um, and this is a type of nodule. A lymph node is referred to a structure that is attached to those lymphatic vessels. There are over 450 of them, right, in your body, and they are receiving fluid through afferent vessels and filtering it out, activating an immune response if needed, cleaning out that fluid, and allowing the passage. So our first question in the study guide is compare and contrast specific defenses and non-specific defenses. What cells are involved in specific defenses? So remember the difference. Non-specific means that they attack anything. And these ones we can think of neutrophils. Okay, they attack anything, they block, they cannot distinguish from one pathogen to another. In specific defenses, we have immunity to specific pathogens, such as the flu. So we have the lymphocytes. The lymphocytes, again, we have different types, but T cells, B cells, and NK cells. All right, and they mount an immune orchestra or an immune reaction that is targeting that specific pathogen, either be the flu, either be some type of bacterial streptococcus. Um, that is the difference. What cells? Again, T, B, and NK cells. So this part number one of the review is going to focus mostly on non-specific defenses, and then we'll dive into specific defenses in part number two. So for non-specific defenses, I want you to think the first barrier is going to be your skin. Your skin is a physical barrier that is preventing the entry of a lot of pathogens into your body, which is a nutrient-rich environment for pathogens. So pathogens do thrive inside of your body. But if they do break in, your body has a host of mechanisms to attack this, even if it doesn't know which pathogen is inside your body. And I want you to think of inflammation as a form to destroy pathogens. Remember that we have neutrophils, we have basophils as a non-specific, and eosinophils as non-specific. Basophils are filled with heparin and histamine. So this histamine is released by basophils, and once basophils releases histamine, we're increasing blood flow, all right, to the area of injury. If we increase blood flow to the area of inflammation, we're now bringing more resources, and it is through chemotaxis and different molecules that communicate the neutrophils that we attract neutrophils to this area. Neutrophils then indiscriminately will start phagocytizing, phagocytize, phago, okay, phagocytize the different pathogens. They will also release chemicals to destroy these pathogens. Neutrophils release hydrogen peroxide, H2O2, and this hydrogen peroxide is highly toxic. When they release hydrogen peroxide, the neutrophils kill themselves in the process, but they kill anything in that section. All right. The eosinophils also start releasing molecules to enhance their action and cause chemotaxis. All right. In this, you can see that we are now seeing the 5 elements of inflammation. If we increase blood flow to this area, we're going to cause redness. It is because the blood is hotter, then we're going to call a heat. the area is gonna swell up because there is more blood flow to that area, and that is swelling. And when swelling occurs, we're gonna start pressing on nerves around the area, and this is going to cause pain. The best acronym to remember these signs of inflammation is an acronym that is called RASH. All right, but remember that the A is pain, so redness, swelling, and heat. What are the differences between lymphatic capillaries and blood capillaries, as well as lymphatic vessels and blood vessels? So, as we talk about a capillary bed, we have our arterial bringing blood flow, then we have our capillary vessels where exchanging all of those nutrients, and then we're moving forward, and that excess fluid is now recovered through that lymphatic vessel. So the first difference between the lymphatic capillary and the blood capillary is that the lymphatic capillary starts as a pocket. You can see here that there is continuous flow in the blood capillary from one side to the other. Here we start from interstitial fluid into the capillary. So the capillary starts as pockets. All right. They have thinner walls. These lymphatic capillaries have a single layer of endothelium. So when there is pressure inside of that interstitial fluid, when there is a higher pressure in the interstitial fluid, as fluid is being filtered out and it starts to accumulate, it pushes on the cell, and the cell allows that fluid to get into that lymphatic capillary. Lymphatic capillaries also have one-way valves. All right, these are different than arterials or blood capillaries. We don't have one-way valves. We have actually sphincters to redistribute blood. There is no muscle in these lymphatic vessels, so we are unable to prevent blood flow or move it. It's very passive. So because there is less pressure on those lymphatic capillaries, there could be a regurgitation of fluid. So we have a one-way valve within these capillary vessels, within these lymphatic vessels, to prevent regurgitation. It prevents return. All right. Remember the order of flow in capillaries. We start from a lymphatic capillary, then we go in through a lymphatic vessel, and those are either superficial or deep, and they join and they form lymphatic trunks. There is about 6 of them, and then once they join, they go into two major collecting ducts, the thoracic duct and the right lymphatic duct. So we have our lymphatic capillary, and we have multiple coming on from multiple capillary beds, and then they join, and then they form a trunk. So this at this level right here will be a lymphatic capillary. At this level will be lymphatic vessels. Once they join, then we have at this level we have trunks, lymphatic trunks. And once the trunks join together, then we have that a lymphatic duct. And it is that lymphatic duct that it dumps into the subclavians. And we have two main sides. We have the right side and we have the left side. The left side is the thoracic duct, and the right side is the right lymphatic duct. Which lymphatic duct collects lymph from the entire body below the diaphragm and the left side of the body above the diaphragm. So we have the right and the left ducts that are the final points of entry and fluid recovery. So you should remember that the right side is bringing less fluid than the left side. I'm gonna put it here, right side and left side. So those ducts, the right lymphatic duct onto the right side, is only bringing blood from the right side, with your right arm, right chest, and right head, kind of like this. The lymphatic duct is picking up the rest of the body, your lower extremities, your head, your left arm. So what lymphatic duct collects the entire body below the diaphragm? The thoracic duct, which is on the left side. There are different trunks that are dumping into this thoracic duct. This is another picture to depict what is happening here. So here we have our subclavian veins, and we have our main ducts, thoracic duct and the right lymphatic duct. The right drainage is covering the right chest, right side of the head, and right arm, and your thoracic duct is picking up the rest of the body. Which duct collects lymph from the right side of the body, superior of the diaphragm? The right lymphatic duct. Okay, this is just a picture to depict. Remember that we're picking above the diaphragm. So if we're talking about abdominal lymphatic fluid, it's recovered through your thoracic duct, so the left side. Which lymphoid tissue or organ will you find concentrated in the neck, armpit, or groin? So we have four different organs. Remember, bone marrow, spleen, lymph nodes, and we have also the spleen. These are our main organs. We have other tissues and we have other cells, but those are the main organs. Our primary organs are going to be, oh, we have a spleen twice. Is it thymus? Our primary organs are bone marrow and thymus. So the lymph nodes, we have over 450 of them throughout your body. They congregate along certain areas, such as the neck, the armpit, the groin, any type of articulation behind the knee. We have a congregation of lymph nodes. These lymph nodes are about 3 centimeters long, and they contain certain structures, but they are filtering that lymph fluid and they're clearing it out. So which lymphoid tissue or organ would you find concentrated in the neck, armpit, and groin? Lymph nodes. This is different than a lymph nodule. Remember that lymph nodules are a congregation of lymphatic cells, and they are ready to attack any type of bacteria that is coming into your body. So those are areas of entrance into the body, such as the respiratory tract. Lymph nodules, we're talking about more something like mucosal associated lymphatic tissue in the respiratory system would be the bowel. Okay, know the difference between the two. What is lymphedema? Lymphedema is a type of disease that can occur as an injury or disruption of fluid recovery in that capillary bed. Remember that we have blood being brought to that capillary bed, and we're filtering and exchanging nutrients. But if we're filtering and exchanging nutrients, sorry, this is just one. If we're changing and exchanging nutrients, we're only recovering a portion of that fluid. About 85% of the fluid that is filtered out is recovered in, but 15% stays within here. 15% stays within interstitial fluid. So if we damage the capillary bed that is recovering that, and we're talking about lymphatic capillaries, if we damage those, then this fluid will stay here and it will swell. It will cause swelling because the cells that are here, that tissue that was being receiving all of these nutrients from this capillary bed, it will start to increase and it will swell the tissue. As you can see here in this picture, there is a lot of swelling in between those cells. There is a lot of interstitial fluid. There are a couple of things. One, injury to the capillary bed so that it cannot be retrieved. Two, you could there could be a blockage upstream of that capillary, that lymphatic vessel. So blockage or damage of that lymphatic drainage. It is causing buildup of interstitial fluid, and that is causing the swelling. There is a risk of severe infection because if you are not bringing all of these, all that lymphatic fluid is being filtered through lymphatic cells to clean it from debris, so you are at a risk for infection because there is not such movement. It is all staying there. How can it happen? It could happen from a couple of reasons. One, traumatic injury. If your body suffers trauma and you cut those lymphatic vessels, trunks, then that section of that limb will be affected. If a patient has cancer or lymphoma, eh, which is cancer within a lymph node, we will oftentimes remove that lymph node. But if we remove the lymph node, then we're cutting the blood flow, so there is no more recovery. So downstream, there is going to be an accumulation of about 15% continuously. Although there are certain bypasses, it is these other the there are other bypasses that also carry lymphatic fluid. These other bypasses do not have musculature to them, so they're not going to increase or decrease lymph flow. They're all just carrying a certain amount. And because there is no filtration, there is a high risk of infection. Oftentimes, the treatment for this type of disease is compresses. So if you put a compression around this arm, some of that fluid will be less likely to accumulate. So these cells right here will be tighter together. If they are tighter together, there is less opportunity for that fluid to actually go into the interstitial fluid. So more of it will stay within your actual blood capillary. Keep in mind that we have afferent vessels and efferent vessels within lymph vessels. So afferent lymphatics bring lymph to the lymph node. All right, so we're going this way, we're going this way, we're going this way, we're going this way. And efferent vessels are leaving. I want you to think of the E as exit. They bring away from the lymph node at the indentation. The indentation of the lymph node is what we call the hilum. All right, this is the general structure of that lymph node. We have is encapsulated. We have trabecula, we have a cortex, and we have a medulla. Which lymphoid tissues protect the epithelium of the digestive, respiratory, reproductive, and urinary tracts? When you think of areas that need protection, you need to think of mucosal associated lymph tissue. And these are areas where there is a congregation of lymph cells because they are exposed to the open. So if they are exposed to the open, there is a higher chance that these pathogens may come in. So these mucosal associated lymph tissues have a high congregation of lymphocytes. So there are different types of mild tissues. When we refer to the respiratory tract, we talk about the bronchial associated lymph tissues. When we're talking about your gastrointestinal tract, we talk about the gut associated lymph tissue. There are other types, but overall, this type of tissue is protective and it has a high congregation of lymphocytes. These areas are at high risk of entry and they communicate with the exterior. We use this malt as a form to defend this area. Another few examples of malt or mucosal associated lymph tissue is your pear patches within your GI system, and tonsils within your oral cavity. Your oral cavity has different types of tonsils, but they are all have multiple rich areas of lymphatic cells so that they are ready to attack any type of pathogen. Inflammation of the tonsils is called tonsillitis. The word a prefix that you want to remember here is itis. When you see itis at the end of a word, it is likely related to inflammation. And as we saw before, inflammation just means that there was an immune response to a type of pathogen, and we're trying to bring blood flow through histamine in order to, one, bring more resources to destroy this pathogen, and we're also destroying the pathogen itself. What is the treatment for this type of infection? If it is through a bacteria, then we will use antibiotics. Remember that we're filtering cells, uh, solutes, nutrients through that capillary bed. That interstitial fluid, it is bringing a lot of solutes, and they go into this lymphatic capillary. All right. Now, the lymphatic capillary is not filtering out, it just wants to pick up whatever it is into that interstitial fluid, either be debris, either be cancer cells. So once the cancer cells go in, the next point of contact here will be a lymph node. So once this cancer cell, we're gonna make it purple, flows in, oftentimes takes a hold of this lymph node, and it starts to divide and then migrates to the next. This type of cancer or cancer within the lymph node is called lymphoma. Oftentimes you could just remove this, but remember that if we remove the lymph node, then we're preventing flow of that lymph, all right, to go. We're removing that flow, so it may cause edema into it. Next question is, the germinal center of nodules contain dividing lymphocytes. So remember that we're talking about nodules as sections of mold. All right, so the germinal center of nodules contain dividing lymphocytes. Lymphoid tissues consist of connective tissue that is packed with lymphocytes. Lymphoid tissues lack a fibrous capsule. The fibrous capsule is seen within lymph nodes. They have a fibrous capsule. We have multiple afferent vessels, and there is a definite outer layer to this. When flowing through a lymph node, the lymph is exposed to what type of cells? Remember that we're exposing it through lymphocytes, which we have B cells, T cells, and NK cells. But we also have another type of cell here, and that is the antigen presenting cells. Antigen presenting cells are also capturing that. We'll put here, antigen presenting cells are capturing antigens, pathogens, and they are presenting it to these cells right here. We will discuss in depth the process of immunity activation for adaptation and antigen presenting cells in the second part. But overall, just know that as lymph is flowing through, there are multiple cells that are querying this lymph fluid to make sure that it is clear. This is the space, subscapular space, the cortex, the deep cortex, and the core medulla. When we're talking about the lymph node, there are different structures within. All right, as we are bringing fluid in, we're leaving in through that hilum, through that kidney section. The first fluid that comes in into the cortex, this cortex right here, and that cortex is rich in B cells. So B cells, if activated, they are the ones that create antibodies. Okay. Now, dendritic cells within the deep cortex. So later on into that deep cortex, we have T cells, and in the core medulla we have more B cells and plasma cells. Okay. This is where actual antibody creation happens. Here we're activating B cells, but the cells are just getting a stimulation. And the T cells are also being stimulated, they're being activated. And eventually when they get here, then it's here where we have most of that antibody production. Let's go through some of the organs. Let's continue to go through some of the organs of the lymphatic system. So we talked about lymph nodes. Now let's talk about the thymus. The thymus is in the superior mediastinum. It is bilobed. It has two lobes. All right. And you can see that each lobe has different sections to it. All right. The next thing that you need to know that is thymus is in the superior mediastinum and behind the sternum. Remember that bone that sits right here? Um, that it is right behind that. What happens to the thymus as we age? The answer is it atrophies after puberty. Remember that the thymus is a place where we are training T cells. T cells are produced in the bone marrow and then they are shifted to the or taken to the thymus where they get trained. About 98% of these T cells get destroyed and only 2% survive. But eventually we will have T cells that are memory T cells that remember all the different types of infections there are. So we don't need to train that many anymore. So eventually this thymus starts to atrophy. Now there is some functionality to it. However, as we age, let's say in the elderly, if it is completely atrophied, well, your immune response is much lower. Remember that if there is a new type of infection and you don't have the thymus to train your T cell regarding this type of infection, well, you are at risk for infections. So what is the consequence of that? In children, if it atrophies way before puberty and you don't have an immune system built up before that, then it will cause infections. It's detrimental to the child. If it happens in adults we oftentimes have already a good immune system built up by then, so it is just normal that it atrophies. But in the elderly, again, by then we may be at risk for infections and your immune system response is attenuated because of that. Okay, in the thymus, lymphocytes divide and differentiate in the cortex of each thymic lobule. Remember that your thymus is a bilobed organ, all right? And the lobes are divided by thymic lobules. Now, each one of these lobules, if you bring it into a magnifying glass, you're going to see that they have a cortex and a medulla. It is in the cortex that we divide those T cells, and in the inside is where we test them. Alright, so we have the blood-thymus barrier isolates the blank of each thymic lobule. Blank cells are important in maintaining the blood-thymus barrier. These cells also secrete thymic hormones like blank that stimulate cell division. So just keep in mind that the blood-thymus barrier, it is meant to keep immature T cells from entering circulation. Because if they enter circulation, they're going to start attacking your own tissues. So we have T cells in the cortex. So this blood-thymus barrier isolates the cortex of each thymic lobule. Now, this barrier is not only made by specific cells in the cortex, but we want to know what those cells are, and those are reticular cells. Reticular cells are the testers of these T cells, and the reticular cells are important in maintaining the blood-thymus barrier. These cells also secrete thymic hormones like thymosin that stimulate cell division of the good cells, of the cells that have passed. Once the genetic makeup of the T cell is past the test, then you can divide onto a, before it is released into circulation. Is there a blood-thymus barrier in the medulla of the thymic globule? The answer is no. So with the thymus barrier is there to prevent immature T cells from entering circulation, because if they enter circulation, they will attack your other tissues. We're probing them, we're testing those T cells to recognize your own tissues. And if they react to your own tissues, they are destroyed. About 98% of T cells that enter your lobule are destroyed. Only 2% make it out. So in this process, we are trying to weed out some of the reactive T cells. But when you get to the medulla, in the medulla, you do not need the blood-thymus barrier because they've already passed the test, and you need them to enter circulation. And in order for them to enter circulation, we need to have removed this thymus barrier. Okay? So the answer is no. The spleen is in the, just remember, in the blank blank quadrant of the abdomen. Just remember to divide your body. So we have our right side, our left side, and on the right side we have the liver. We have the spleen. We have the urinary tract. We have the appendix. We have the colon. So here, because it is divided into quadrants, this will be the left upper quadrant. Removal of the spleen is called a splenectomy. A splenectomy oftentimes is done when a person undergoes trauma, and with this trauma, we're unable to repair the spleen. The spleen is very delicate, so if you try to dissect or try to suture the spleen, you're going to cause more bleeding. So the best way to reduce complications is sometimes removing the spleen. If you remove the spleen, you are at a higher risk for infection. Remember that the spleen is a lymphatic organ that is filtering out all of these infectious patterns, infectious pathogens. Remember that we have our spleen and we have specific capillaries within the spleen, and those are sinusoid capillaries. And within these sinusoid capillaries, we have huge gaps that allow macrophages to probe the blood and check for infected cells, pathogens, as well as fragile red blood cells. If we remove the spleen, that action of the macrophages checking out your blood for pathogens will be decreased, won't happen anymore. So that leaves you at a high risk for infection. Make sure you know your non-specific defenses. We have physical barriers such as the skin. We have leukocytes such as neutrophils. We have immunological surveillance. We have interference, and we have complement, inflammatory response, and fever. Let's talk a little bit about interference. Interferons are molecules that are secreted by neutrophils when neutrophils are being infected by a virus. So when a virus infects a neutrophil, right, the virus inserted itself into it, brought its DNA and genetic material into that neutrophil, it will try to use and it will try to hijack the machinery from that neutrophil to divide itself. And eventually, once it's used all the nutrients and resources from that neutrophil, it will burst open and release all of these viruses to infect other cells. When that is happening, the neutrophil is releasing interferons. These are molecules that go on to communicate to other surrounding cells. And these interferons tell this cell right here, hey, look, there is a virus. And these interferons cause a cascade reaction, telling this cell to start creating antiviral molecules. And these antiviral molecules will make it harder for that virus to destroy this cell. These interferons work best under inflammatory responses because of elevated temperatures. Complement. Complement is I want you to think of complement as a collection of proteins that are free floating in your body. They are made by the liver, and during an inflammatory response or infection, they are activated in adaptive immunity. Now, they also uh, activate themselves spontaneously in order to keep track of innate defenses. So let's talk about C3. There are different types of uh, proteins within complement. You know that it's a complement protein because it stands with C and there will be a number right next to it, such as C5 or C6. We're going to focus on C3. Once C3 becomes activated, it divides into C3A and C3B. You know it's activated because it has a letter associated to it. All right. Now the C3A aids in inflammation. It increases inflammation. C3B goes on to coat the pathogen. Okay, it binds to the outer section of that pathogen. This activation can happen in two ways. Either one, through an spontaneous division and then finding the pathogen, or two, through an immune response of an antibody. All right. Right now we're going to focus on the non-specific, so the spontaneous breakdown of C3 into C3A and C3B. C3B then coats the pathogen naturally. If a pathogen breaks in, this one will, C3B, will start coating this section and it will cause a fixation. Now it is easier for macrophages to engulf this bacteria and destroy it. Which immune system component works by releasing perforins that form pores into the target's cell membrane? And what other chemicals do the above cells release? When when you think about immunological surveillance within innate systems of a defense, I want you to think of NK cells, which stand for natural killer cells. Natural killer cells are within your body probing tissues for disease. So if they see we're gonna think of a tissue right here, a tissue right here, and a tissue right here. If this type of cell was infected by a virus and their machinery was hijacked and you are now producing more viruses in order to be released to attack the next cell, there is a receptor outside of this cell that is called the MHC1 receptor. This MHC1 receptor is showing an antigen of health of this cell itself. So if this cell is sick, the antigen of health will change and it will try to activate an immune response so that it can attack the cell before it bursts open and all of these viruses go on to attack neighboring cells. This MHC1 is probed or checked by a couple of cells. Two cells do this: T cytotoxic cells and NK cells. So if there is an abnormality within this antigen presented through MHC1, T cells are going to cause a response to destroy the cell so that it doesn't release the viruses. Now, sometimes the viruses may themselves prevent the expression of that MHC1. So if the MHC1 receptor that is meant to show an antigen of health, a status of the cell inside, then the virus prevents the MHC1 from forming. Okay, so the virus will try to replicate inside, and the T cell won't be able to attack it because it doesn't know there is something wrong inside. There is where the NK cell comes about. The NK cell monitors for the presence of MHC1, and if it sees that there is a lack of that MHC1 receptor, it will then attack this one, and it will attack it in a specific way. It will create a hole through perforins, and after it creates a hole, it will then introduce granzymes, and these granzymes will lead to apoptosis, so that then this one won't release those viruses. In a cancer cell where there is a mutation, there is something ill or something bad going on with this type of cell, okay? The genetic material has led to a well, we'll discuss cancer in a different time, but the idea is that the genetic material is dividing without a step, all right? And the cell is going to divide. Now, this MHC1, which is the receptor of health, presenting that status of health, will change in a will change in cancer cells. And if cancer cells show MHC1, well, cytotoxic cells will attack it. Let me just show that change right here. This is like a sig. It's showing that change in that status. So because of that lack of resources, we're trying to use it to divide new cells in cancer cells. NK cells are also monitoring, and if they see that there is a lack of that MHC1 receptor, then they themselves destroy the cell, regardless of whether or not they have confirmation there is something wrong inside. They assume that there is something wrong inside because the MHC1 receptor is not there. So then again, we have perforins breaking that cell membrane and then introducing some of those granzymes to induce apoptosis, and it is no more. Which cells are macrophages and how they differentiate from macrophages? The key distinction here is that they are both phages. Phagocytes means that they engulf debris, they engulf cells. Now, the degree as to what they do it is where the difference comes from. Macrophages, such as neutrophils and eosinophils, they engulf a smaller type of the debris or a bacteria. Macrophages, which derive from monocytes, are large phagocytic cells. They can engulf big bacteria. Eosinophils are engulfing rather antigen antibody complexes. All right, neutrophils are engulfing small bacteria, large bacteria. Blank are the leukocytes that are not phagocytes. How do these cells work? So when you think of the leukocytes, I want you to write the acronym: never let monkeys eat bananas. So the neutrophils are phagocytes. They phagocytize debris, toxins, pathogens overall, depending on their size. Lymphocytes divide into T cells, B cells, and NK cells. So B cells are antigen presenting cells, but they don't really phagocytize. Okay. T cells also aid into that immune response. Monocytes, then develop into macrophages. Those are big phagocytic cells. Eosinophils also phagocytize, but they are macrophages. So they are phagocytizing smaller molecules related to immune response. Basophils do not have phagocytic capabilities, however, they do aid in a different way. They aid by releasing histamine and heparin. So when we release histamine, we increase blood flow to the area of injury. And when we increase blood flow, we cause redness, swelling, we increase heat, and remember that interference work with heat, so there is a attenuated response or a decreased effect from those viral proteins. Histamine dilates blood vessels and brings other resources, and we are releasing also heparin because, and this is also locally, it's not going to be systemic, this is all local. We want to prevent blood clots from preventing some of that recruitment of resources to the site of injury. All right, so interference are key players in the fight against blank. They work by inhibiting blank blank. So when you think of interference, you should think of viruses. So they are key players against the fight against viruses. And they work by inhibiting viral replication. There are different types of interference. For the purpose of this class, you do not need to know the difference amongst them. However, know that there are different types depending on the cell that is releasing them. For instance, if we have a neutrophil, all right, our leukocyte, that has been infected by this virus right here. Now this virus is injecting all of its DNA material within this neutrophil, and this DNA material is trying to hijack the machinery of this neutrophil. And by doing so, it is now replicating itself within, with all the resources within, so that it can then burst open the neutrophil and go on to infect other cells. While that is happening, the neutrophil is releasing interference. And these are molecules that are trying to alert surrounding tissues. Now, once the surrounding tissue is alerted, it will then produce antiviral proteins so that when the virus comes in to inject its genetic material within, it is less likely to overtake this healthy cell. In this case, we're talking about the release of interference by lymphocytes. When lymphocytes release interference, they not only alert other cells, but they also activate macrophages and NK cells so that they can slow the prevention of viral cells. You are now telling these NK cells and macrophages to digest that infected cell. So, for instance, if we have a cell that has been infected, now the activated NK cell through those interferons will eat this cell before it can then spread all those other tissues. So antiviral proteins do not kill viruses, they block viral replication in the cell. Okay. The complement system includes complement proteins that assist or complement the function of antibodies. All right. We'll put it here, antibodies. So what is the complement system? The complement system is a conglomeration of proteins that are made by the liver. You will know that they are, we're talking about the complement proteins because all of them start with a C. Their name starts with a C. That stands for complement. All right. Now, there are different proteins, and there is three, there is C5, C6, but nonetheless, when they are in circulation, they are inactive. And you will know they are inactive because they are without the letter. Once they become active, we term it as C3A or C3B. All right. Now, C3A aids in inflammation, and C3B, it is in the coating of that bacteria or cell. This is the actual molecule that starts attaching to the sites of that antibody. So for instance, there is a bacteria that we've had an immune response before, so it has antigens in the outer portion of it that we know what they look like, and we have floating antibodies that match it. So we attach antibodies, and these antibodies now open up sites for the C3b protein. So the C3b will bind here, 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 and it will cause a fixation of proteins that will make it easier so that when the macrophage is about to engulf it, knows, oh, this is the one that I need to eat. All right. So the C3b is coding that pathogen itself. C3a is helping more so with inflammation. Each one of these are creating a cascade reaction. We could activate complement through different pathways, that is the classical pathway, the alternate pathway, and the lectin pathway. All right. The classical pathway is through antibodies, okay, and this is related to humoral immunity, and we'll discuss this again when we talk about the specific defenses. But the alternate pathway and the lectin pathway are related to the innate defenses. The classical pathway, again, it is how we just described it, where we have an antibody, stimulating that C3b, fixation of molecules. Within the alternate pathway, we have just a passive division of C3 into C3a and C3b, so that C3b can then just fixate onto a molecule protein. The end result of the C3, C3a, C3b is conglomerate with other proteins to create a complex. When they bind together, they create like a ring. C3a, C3, C5, C9, and multiple dozens of them. But they create a complex that when they bind to the cell membrane of that pathogen, create a hole. And that hole is so big that all the nutrients within this pathogen will leak out, creating cytolysis. All right. But overall, the complement system includes proteins that assist the complement of antibodies, more so within the classical pathway. So when we have a complement bind to antibodies to improve opsonization, this is the concept that we just discussed, where we have C3 divided into C3a and C3b. C3a goes to help with inflammation, so recruitment of resources, and C3b is the one that actually binds to that pathogen. C3b, 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 and when it is bound to that, now the macrophage knows that it can eat it, or that it can phagocytize it. Um, there are a couple of effects from complement activation. Again, one is it is aiding in opsonization, which is the phagocytation of that. The phagocytation. Opsonization just means that we have C3b proteins coding that pathogen. Now that is making it easier for the macrophage to phagocytize this pathogen. Effects of complement activation. We have pore formation to destroy target cell membrane. Remember that that is the end result. Once we have all the proteins fixated together, we create a membrane attack complex. And that membrane attack complex allows for that cytolysis, or the breakdown of that pathogen, by leaching out all of the nutrients within, and the cell cannot maintain anymore its homeostatic state, and it destroys itself. The C3b coding or opsonization is what is enhancing that phagocytosis of the macrophage. C3A is enhancing histamine release. So C3A goes onto basophils and mast cells so that histamine is released. And there is histamine release. Remember that we have more inflammation, we have more blood flow, we have a heat, interference are working better. Complement activation leads to the splitting of C3 into the active molecules. And remember that the complement proteins are made by the liver and they are inactive in circulation. But once they become active, either be from an antibody or from a spontaneous division, when they become activated, they're going to C3A and C3B. All right. These proteins join with other proteins to form the membrane attack complex, or MAC. So it is not like the complement routes are just specific to one function. They could do multiple things depending on the situation. But overall, that C3b may bind with C5, C6, and then form a huge complex that attaches to the membrane of the pathogen, creating a hole leading to the cytolysis of that pathogen. What are the cardinal signs of inflammation and what causes inflammation? Remember that within inflammation or an inflammatory response, we have a local response because there is a release of histamine. This release of histamine is causing hyperemia or the increase of blood to this local section. And when there is more blood flow, there is redness, all right, because there is more red blood cells. And because blood is hotter than is running hotter than body temperature, then there is an increase in temperature. There is pain because as there is hyperemia, there is more blood flow to this area. We're filtering more into the interstitial fluid, and this overflow of interstitial fluid is going to press on nerves and they cause pain. These are the cardinal signs of inflammation. A good acronym to remember them is RASH, but remember that the A is pain. An abnormal elevation in body temperature is called fever. Know the different levels. So this is in degrees Celsius and this is in degree Fahrenheit. Here in the US we use Fahrenheit, so just know that above 99 it is considered a fever. This temperature enhances immune responses such as interferon work. However, if it is too high, it is now not conducive to life. It may kill you. Um, just know the ranges for fever. Fever improves the immune response. The answer is yes. What chemicals cause the hypothalamus to raise the temperature set point? The molecule that goes on to rise temperature is pyrogens. Pyrogens are a materials that work in the hypothalamus and they increase that set point. There are different types of pyrogens. There is exogenous and endogenous. So exogenous means that they are foreign, okay, such as bacteria. Bacteria may go in and cause that increase in set a temperature point. Endogenous means activated by your own cells, such as neutrophils. Neutrophils release interleukins, all right, because they're trying to fight an infection. So they're telling your body that they need to increase that body temperature. So we need to increase that metabolic breakdown of molecules so that we can increase temperature. All right, so within fever, remember that we're using fever as a mechanism to enhance that immune response, and fever is happening as a result from pyrogens or molecules that are either endogenous or exogenous. These pyrogens are cytokines basically that go to the hypothalamus and are telling, hey, look, there is an infection. And the hypothalamus then goes on to release prostaglandins onto itself. All right. So when it releases prostaglandins, it increases the temperature set point. And when we increase the temperature set point, your body won't try to fight the fever once it starts because it knows that the fever is a form of response and it is good for you. How is it that we increase body temperature? We increase it by constricting the periphery, the cutaneous blood vessels, and bringing it to the, to our vital organs, and we induce shivering. So when we're shivering, we're utilizing muscles to break down molecules to increase heat. So we have that cold and clammy shiver and the cold and clammy feeling. All right. We have different medications that we can use to break down the fever once it is past the infection. But just know that fever initially it is a good thing because it is trying to utilize its innate defenses to destroy a virus or a pathogen. The fever sometimes it may naturally subside if the prostaglandins or if the prostaglandins decrease on its own. So if the bacteria is destroyed, there will be a decrease in cytokines or pyrogens, and that decrease in cytokines will tell the hypothalamus to stop the prostaglandin production, and the body temperature will come down to normal. This will take time, and in that time, you may run the risk that the fever runs too high. When you are getting right above 105, the patients may become delirious. Above 110, you will start denaturing the cells, your own cells, and you may have brain cell death. Your own molecules will start to die. So you don't want it to go too high. So that is why we have medications to break it down or to control it, such as Tylenol or acetaminophen. Acetaminophen, what it does is it decreases the production of prostaglandins. So if you don't have as many prostaglandins, then you cannot tell your hypothalamus to increase the temperature set point.